I'm going to begin with a question. Diagnostic reasoning is, in simple terms, collecting data from a patient and formulating a diagnosis from it. My question for you is, how does our brain do it? How do we get from point A to point B? Can someone give me a basic description of diagnostic reasoning? You're not alone. Currently, there's no single agreed upon description. In fact, there's at least three. System 2, System 1, and Bayes. I'll describe each in more detail later. Suffice it to say, they're all problematic. So the purpose of this talk is to provide a basic description of diagnostic reasoning. But why is this important? It's important because of medical error, a huge problem, as most of you know. And a major component of medical error, if not the biggest, is diagnostic error, estimated at 12 million diagnostic errors a year in the US, or about 10% of all your diagnoses. It's the most common reason we harm patients and the most common reason for a doctor to be sued. Although other factors outside of the physician, like uncooperative patients or communication errors or system errors in the hospital, contribute to diagnostic error, there's a physician component in almost 100% of cases. So how do we get diagnosis wrong? Most of us are neurotic about our knowledge, that we haven't memorized all the 13,000 diseases. But in retrospective analysis of these errors, faulty knowledge is relatively uncommon, according for only 3%. This is because most misdiagnoses occur in very familiar disease, like cancer, vascular disease, and infection. More mistakes are made with data gathering, like forgetting to ask a question in the history, examine a body part, or order the right test. But the lion's share of our errors seem to be due to faulty reasoning. We had the knowledge, gathered the appropriate data, but missed the diagnosis because we failed to put it all together, failed to get from point A to point B. So if we're going to sharpen our diagnostic skills, a basic description of diagnostic reasoning is fundamental. So let's begin. One thing we do know about diagnostic reasoning is that it's easily derailed by cognitive bias. Our brains are hardwired to solve problems with as little effort as possible. We are cognitive misers. So we use shortcuts called heuristics, and we're unaware our brains are doing this, which leads to predictable errors called cognitive bias. There are many in diagnostic reasoning, and they're well documented. Let me demonstrate a few by way of an old medical joke. The internal medicine team is stumped by a complex patient. To make things worse, the patient has a fall. So ortho is called in to evaluate. As she leaves, she tells the team, "This patient has schistosomiasis." At their wits' end, the team thinks, "What do we have to lose?" orders the test, and lo and behold, the test was positive. The stunned medical team calls the ortho back and asks, "How did you know the patient had schistosomiasis?" She replies, "What else can cause an enlarged liver?" Can anyone name a cognitive bias? There are several. To begin with, the base rate fallacy. The orthopedic surgeon failed to consider the base rate or prevalence of the disease in this patient. How common is schistosomiasis in North America? Usually expressed with a popular aphorism, "When you hear hoofbeats, don't expect to see a zebra." But wait a second. Hasn't the medical team committed the same fallacy? Yes, they neglected to consider the base rate when interpreting the schistosomiasis antibody test. Let's say the accuracy of that test is 99%. Does this mean with a positive test, the patient has a 99% chance of schistosomiasis? No. The probability of having a disease is equal to the pretest probability of that disease, which is the base rate, multiplied by the accuracy of the test. So if the pretest probability of schistosomiasis in North America is, let's say, 1 in 10,000 or 0.01%, a positive test with a 99% accuracy improves or updates the probability by 2 decimal points to about 1%. Tests do not diagnose disease. They update the probability of disease. you're still unlikely to have a rare disease even with an accurate positive test. What's the name of this kind of reasoning? Correct. Bayesian reasoning. So if you're an orthopedic surgeon and some smug internist tells you this joke, bring up Bayes, it turns out the joke's on them. Another cognitive bias is the availability heuristic. We tend to diagnose patients with diseases that easily come to mind. And diseases that easily come to mind are ones we've diagnosed in the past and ones that are dramatic. When the orthopedic surgeon heard enlarged liver, maybe the first thing that came to mind was an unforgettable case of hepatic schistosomiasis from medical school. We also tend to diagnose from pattern recognition. This is called the representativeness heuristic. We jump on a recognizable pattern of signs and symptoms. But this only works when the pattern is highly accurate or pathognomonic, and when the pretest probability is taken into account. For instance, this is Tom. Tom is an opera buff. On vacation, he enjoys touring museums. And when growing up, he was on the chess team. Is Tom's vocation a trumpeter in a symphony or a farmer? The representativeness heuristic is pulling us to say trumpeter, but let's calculate the pretest probabilities. With about 100 orchestras, there's 300 trumpeters in our entire country of 300 million. Therefore, the pretest probability of being a trumpeter is about 1 in a million. With 3 million farms, the pretest probability of being a farmer is about 1 in 100. Because farmers can also play chess and enjoy museums, Tom is far more likely to be a farmer. Applying this to diagnosis, an atypical presentation of a common disease is more likely than a typical presentation of an uncommon one. These cognitive biases all lead us to the wrong diagnosis. The next group make us stick with it. Premature closure is our tendency to be satisfied with the first disease that matches the signs and symptoms of our patient. It's a direct result of being cognitive misers. The orthopedic surgeon was satisfied with the first explanation of enlarged liver that came to mind. She should have looked up the differential and considered alternatives, but she did not. In radiology, they say the most commonly missed fracture is the second fracture. We also tend to accept a diagnosis made by our colleagues, or a diagnosis we find in a chart, instead of evaluating it for ourselves. This is what's meant by diagnostic momentum, yet another consequence of being cognitive misers. And finally, to maintain the diagnosis we arrived at, we give excessive weight or anchor to signs and symptoms that confirm it and ignore signs and symptoms that do not. This is the anchoring or confirmation bias, which is backwards. We should be trying instead to prove our diagnosis wrong. In summary, cognitive biases either lead us to the wrong diagnosis or keep us there. So a description of diagnostic reasoning should take cognitive biases into account. And we can derive the following basic requirements. Our description of diagnostic reasoning should make us slow down and think. It should make us aware that we start the diagnostic process with diagnoses already in mind. We are diagnosis laden. It should make us aware of the pretest probability of the disease we are proposing and the accuracy of the tests we're using. It should force us to consider alternate diagnoses and compare them fairly, and give us objective criteria to help us ultimately decide should we accept or reject the diagnosis. So now let's see how these three descriptions of diagnostic reasoning mentioned at the beginning, System 2, System 1, and Bayes, perform with respect to these requirements, starting with System 2. System 1 and 2 are part of the dual process theory of thinking. Cognitive scientists believe that our brains solve problems either fast or slow. System 2 is the slow process. It is analytical and we're conscious of it. It is the process a student is taught when starting to learn a new skill. When we learn diagnosis, The textbook description from the Institute of Medicine is: begin by acquiring a cue. A cue is the main sign or symptom of the patient, the chief complaint, found by performing a history and physical. For example, we interview a 36-year-old female, and she complains of intermittent headache with nausea for 6 months. This leads to formulating a working diagnosis, such as migraine. We then interpret the cue. If the head is a migraine, the patient should have photophobia, and test this interpretation by asking the patient, do you have photophobia? Remember, tests aren't just scans, labs, and biopsies. They're also symptoms, examination findings, and risk factors. They're all tests of our diagnosis in one form or another. If the test is positive, we accept the diagnosis. If the test is negative, we reject the diagnosis and go back to step 1. This model has several shortcomings, beginning with the first step, acquiring a cue. How do we know which cues are relevant? We can endlessly interview our patient and find an infinite number of cues. We have to choose something or we're paralyzed. So our interviewing is guided by a diagnosis we already had in mind. We chose headache because we had migraine in mind. Cue acquisition is diagnosis laden, a problem this model doesn't address. Nor does it make us consider the pretest probability of the diagnosis before we test it. What's the probability of migraines in a 36-year-old female? Nor the accuracy of the tests we're using. How sensitive and specific is photophobia for migraines? And it doesn't help us decide whether we ultimately accept or reject the diagnosis. For example, even if our test is negative, the patient doesn't have photophobia. It may still be migraine, but an atypical presentation. Diagnosing atypical presentations is certainly part of diagnostic reasoning, but we get no help from this model. And finally, this model reduces all diagnostic reasoning to diagnosis testing. Is that the only way to evaluate a diagnosis? What about comparison with an alternate diagnosis? This too is a big part of diagnostic reasoning, but not part of this model. So System 2 is good because it makes us slow down and think, but it fails to meet our other basic requirements. Eventually, after many years and thousands of hours of practice, students become experienced clinicians. Patterns emerge, and the slow conscious thinking of System 2 is replaced by the fast automated thinking of System 1, the other side of the dual process theory. The best example of this is driving a car. Try and recall how much you concentrated on the mechanics of driving when you first learned. That was System 2. Today, you probably don't even remember driving to work. That's System 1. Quick, what's a diagnosis? Correct, shingles. If it took you more than 300 milliseconds and you had to think, you're not an experienced clinician and not using System 1. System 1 is fast. It is unconscious. Your brain does it without consulting you. And it works by pattern recognition. Experienced clinicians spend most of their time in System 1. Fortunately, there's a failsafe. When a pattern is not recognized, like in a complex case or atypical presentation, experts will toggle back to System 2, slow down, and start testing diagnoses. But System 1 has some shortcomings. The pattern recognition and its fail-safes are only as good as the quality of practice when learning. Did the doctor through the years deliberately seek out feedback and find out where they went wrong? This is the difference between practice and deliberate practice. A good musician doesn't practice the entire piece, they practice the section they're bad at over and over again. An experienced clinician without deliberate practice is not an expert. They're just creating shortcuts and automating their mistakes. Sound familiar? Yes, they're consolidating their cognitive biases, which may explain why some studies show older, more experienced doctors have worse patient outcomes than younger ones. And for the purposes of this talk and the search for a description of diagnostic reasoning, System 1 is not a description. It's just the pattern of diagnostic reasoning. So we'll have to look elsewhere. Our third description of diagnostic reasoning, Bayes, is also not a description of diagnostic reasoning, but rather a component of diagnostic reasoning. As I showed you earlier, when testing a diagnosis in System 2, Bayes forces us to apply probabilistic thinking, making us account for the pretest probability of the disease and the accuracy of our test. Bayes is great, but it's not a full description of diagnostic reasoning, and real numbers are hard to find. For example, I couldn't find the actual pretest probability of schistosomiasis in North America, nor could I find the sensitivity and specificity data on antibody testing, making Bayes impractical for everyday use. Because System 2, System 1, and Bayes all fail to provide a good description of diagnostic reasoning, a search outside of medicine to see how other disciplines describe reasoning may be more fruitful. The reasoning of detective work, for instance, is quite similar to diagnosis. The victim's stab wound was on the right side of the neck, angled downwards. This suggests the killer was a tall, left-handed male. In fact, Arthur Conan Doyle, the writer of Sherlock Holmes, was a doctor. What did Sherlock call this kind of reasoning? Correct, deduction. But this is not deductive reasoning. So let me give you a primer on our current understanding of reasoning from the philosophy of science. There are two main types of reasoning: deductive reasoning and inductive reasoning. What's our modern description of deductive reasoning? Deductive reasoning is an argument in which the premises guarantee the conclusion. Here's a classic example from antiquity. All humans are mortal. Socrates is human. Conclusion: Socrates is mortal. If the premises are true, the conclusion must follow. However, other than mathematical proofs and categorical arguments like this, there are very few arguments in the natural world that can be guaranteed. So for everything else, we use inductive reasoning. All science is inductive reasoning, including detective work and diagnosis. For example, I see a white swan. I see another white swan. Conclusion: all swans are white. Even if the premises are true, they only support the conclusion. They cannot guarantee it. Are we certain all swans are white? Have we searched the entire planet? This is known as the problem of induction, identified by Scottish Enlightenment philosopher David Hume in the 1700s. Induction is dependent on the uniformity of nature, that nature is uniform in time and space, which it is not. In fact, around that time, we found black swans during the exploration of Australia. So inductive arguments cannot guarantee the conclusion, only support it. And this is why science can never be right. It can only be less wrong. The reason this is important is that the same holds true for detective work. We can never be certain the killer was a tall left-handed male. They could have been a tall left-handed female, or a tall right-handed female who approached from behind, or a short right-handed female attacking a victim who was kneeling. And similarly, diagnostic reasoning is imperfect. We can never guarantee a diagnosis, even if the diagnosis is based on perfectly matched signs and symptoms. We can be still completely wrong. For example, in infectious disease, a patient could acquire a new and unknown disease presenting exactly like the old one. Therefore, our goal is not to make diagnosis perfect, only to improve on it. In fact, learning to accept uncertainty may make us better diagnosticians. So diagnostic reasoning is inductive reasoning, and inductive reasoning is how we reason in all of science. We also call scientific reasoning the scientific method, a term you should be more familiar with. What is a description of the scientific method? The classic textbook description is: you observe, you hypothesize. Based on the hypothesis, you make predictions and test the predictions. If the predictions come out true, you accept the hypothesis. If the predictions come out false, you reject the hypothesis and go back to step one. It's called the hypothesis testing model. Sound familiar? Yes, it's the same model we're taught for diagnosis, the diagnosis testing model of System 2. And it has exactly the same problems plaguing philosophers of science for centuries. When we begin observing, our observations are laden by the theories we're trying to prove. Our observations are theory-laden, not accounted for by this model. When we test our theory, this model says nothing about the accuracy of the test. For example, an anecdote fits this model. I am sick. I found a pill on the ground. I hypothesize it'll make me better. I will test the pill by taking it. I took it and now I'm better. Therefore, the pill works. It fits this model, but certainly not good science. Good science is about setting up accurate tests to try to prove ourselves wrong. We can endlessly find more white swans. There's plenty of them. It's far better to search for black swans. All we need is one. Good science is falsification, not confirmation, but falsification is not part of this model either. And once we test our theory, this model doesn't help us decide whether ultimately we should accept or reject. Many times in science, we accept a theory even though it failed the test. Let me give you a classic example. By the 1800s, Newton's laws were successfully used to predict the motion of all the planets, except Uranus. So should we reject Newton's laws or try to save them with an excuse, like there's a yet unseen planet pulling on Uranus? And this is exactly how we discovered Neptune. Sometimes we don't listen to our tests. This is clearly part of scientific reasoning, but not in this model. And just like System 2 reduces all diagnosis to testing, this model reduces all science to testing. Aren't there other ways to evaluate a theory? Yeah, we can compare theories to other theories. It is clearly part of scientific reasoning. Let me demonstrate. Both the geocentric model of our solar system and the heliocentric model of our solar system passed all our tests. They equally helped with navigation and could predict celestial events like eclipses. The test that finally proved the heliocentric model was parallax. Stars change position relative to one another depending on the season of the year. But we lacked the technology to show parallax until the 1800s. So why did we accept the heliocentric model well before this test? We used other criteria to compare these theories. The geocentric model had an anomaly. It was well known even before the invention of the telescope. If you observe the planets in the night sky from week to week, like Mars in this video, the planets make strange loops or epicycles. Astrologers call them a planet in retrograde. So the bird's eye view of the geocentric model looks like this. Planetary motion is disorderly and complex, an anomaly hard to explain. However, the bird's eye view of the heliocentric model looks like this. Planetary motion is orderly and simple. It only appears anomalous from our perspective because we are in rotation. Anomaly explained. The heliocentric model is the simpler explanation and therefore the better explanation. We were able to distinguish between models without testing. What's the name of this kind of reasoning? This is abduction, or inference to the best explanation. And since I'm speaking with doctors, not this kind of abduction, but a kind of reasoning, abductive reasoning. We actually do it all the time intuitively, like when we correct misspelling. Look at this sentence. What's more likely, that I misspelled the word so and meant to write saw, S-A-W, or that I'm commanding someone to sew an image of what happened? What's the better explanation? Every time we determine the best explanation from alternatives, we're using abductive reasoning. By the way, any spelling mistakes in my talk is just another demonstration. Thomas Kuhn, in his body of work, including the famous The Structure of Scientific Revolutions, lays out the argument that abduction, not hypothesis testing, is the best description of scientific reasoning. He shows, using multiple examples from the history of science, that science is done within a paradigm, a meta-theory. After time, anomalies unexplained by the paradigm mount up. And if a new theory emerges that explains everything the old one did plus the anomalies, the new theory is seen as the better explanation, and a paradigm shift eventually occurs. What criteria do we use to compare theories? The best resource for this is Schick and Vaughan's How to Think About Weird Things, Critical Thinking for a New Age. They provide 5 criteria. The first 2 incorporate hypothesis testing. Testability, does the theory make novel predictions? And fruitfulness, does it get those predictions right? The other criteria are scope, which is also known as explanatory power. How much does the theory explain? Does it unify our knowledge? Or does it invoke the inexplicable and raise unanswerable questions? Simplicity. How many assumptions or entities does it require? You may know this as Occam's razor. All things being equal, the simplest explanation is most likely the correct one. The heliocentric model was simpler than the geocentric model. And finally, conservatism. How well does the theory align with what we already know? Let me provide one of Kuhn's examples from the field of physics. When Einstein introduced relativity, it was not conservative. Our best explanation of space and time at that point was Newtonian physics. It was the paradigm. But eventually, relativity became more fruitful, predicting light bends around massive objects. It had more explanatory power, explaining time dilation and Mercury's anomalous orbit, and had a simpler explanation of gravity, a warping of space-time. All of this forced a paradigm shift, and now relativity is the conservative model. Abductive reasoning can be used to evaluate almost anything. Pseudoscience, the existence of ghosts, Bigfoot, or UFOs, and theories in medicine. For example, homeopathy. What is homeopathy? For starters, it's not herbal medicine. It's a very unique system of healing proposed by Samuel Hahnemann in the 1700s. He claimed a substance which harms a healthy person will treat an unhealthy person complaining of the same symptoms. And the more the substance is diluted in water, the stronger it becomes. Caffeine, for instance, causes insomnia in a healthy person, so it will treat insomnia in a person complaining of it, but only when diluted to a dose where no caffeine molecules are left. Now let's apply abduction to evaluate homeopathy. Is it testable? Yes, patients should get better. Is it fruitful? Yes, homeopaths see patients in practice get better. If we relied on hypothesis testing alone, we would accept homeopathy at this point. But with abduction, we go on to assess further criteria. Does homeopathy have scope and unify our knowledge? No. It invokes the inexplicable. It claims to work because water remembers the essence of the substance it was in. This just raises more questions. How does water remember? And why doesn't drinking tap water kill us? Is homeopathy simple? No. It requires extra assumptions, like water having memory and substances having essences. Is homeopathy conservative? No. It completely conflicts with what we already know. Physics, chemistry, biology, and pharmacology all tell us the more we dilute, the weaker things get, and nothing is left when dilution goes beyond Avogadro's number. For homeopathy to be right, everything we know has to be wrong. So these other criteria provide us with a pretest probability of homeopathy and allow us to assign a weight to the testing. Because the pretest probability of homeopathy is so low, the positive test, anecdotes of patients getting better, is inadequate. But we don't stop here. Abduction is inference to the best explanation. What's another explanation for what's going on? Evidence-based medicine. It explains why the homeopaths were fooled. Without a control group, Patients get better because of placebo effects and the natural history of the disease. Are the claims of evidence-based medicine testable? Yes, and with a better test, a test that tries to falsify a randomized placebo-controlled trial. Is evidence-based medicine fruitful? Yes, homeopathy does not work in a well-done randomized trial. Does evidence-based medicine have explanatory power? Yes, it not only explains why homeopaths are fooled, but unifies our knowledge, explaining why we're all fooled at one time or another by other implausible medical claims. Is homeopathy simple? Yes, it requires no extra assumptions. Is evidence-based medicine conservative? Yes, it aligns with all other sciences. Scientific reasoning is more than hypothesis testing. It is abduction. As such, detective work is more than hypothesis testing. It is abduction. And diagnosis is more than diagnosis testing. It too is abduction. So let me finally describe diagnostic reasoning for you. Diagnostic reasoning is finding a disease that, when compared with others, is the best explanation for the patient's signs and symptoms. Let me demonstrate how it works in practice. A patient presents with signs and symptoms that demand an explanation. We start off just like System 2 and generate a working diagnosis. Let's call it Diagnosis 1. And test it with additional signs and symptoms that Diagnosis 1 predicts. But to help us interpret the results of these tests, we evaluate our other criteria. Does it have scope, explaining most of the signs and symptoms? Is the diagnosis simple, Occam's razor, and explains everything with a single diagnosis instead of proposing two diagnoses occurring at the same time? And is the diagnosis conservative, meaning, is it prevalent and scientifically well established? For example, schistosomiasis is not conservative because it's not prevalent in North America, and leaky gut, Candida hypersensitivity syndrome, and Qi imbalance are not conservative because they're not scientifically well established. These other criteria generate a pretest probability and give weight to our test. For example, when a disease is going around, the pretest probability is so high we often ignore our tests. In April of 2020, the most wide-scoping, simple, and conservative explanation for a patient presenting with severe respiratory tract symptoms was COVID. We diagnosed it even when the antigen test was negative. Our next step is to generate an alternate diagnosis, Diagnosis 2, a diagnosis that's also consistent with the signs and symptoms, and perform testing on it and evaluate the other criteria. We're all familiar with this step. In diagnostic terms, it's creating a differential. The more alternate diagnosis we compare, the more robust the process. Let's go back to our 36-year-old patient with intermittent headache with nausea for 6 months. Our Diagnosis 1 was migraine. We were going to test it by asking, do you have photophobia? She does not. So do we reject the diagnosis? No, not yet. Let's evaluate our other criteria. Is migraine wide-scoping? Yes, it explains all her signs and symptoms. Is migraine simple? Yes. To explain nausea with other causes of headache, we would have to invoke a second diagnosis like gastritis. Is migraine conservative? Yes. It's both very common in this demographic and scientifically well established. Because migraine has such a high pretest probability, our negative test, no photophobia, doesn't carry much weight and shouldn't make us reject migraine. Let's think of another diagnosis that accounts for our symptoms. Brain tumor. Let's test it. Are there focal neurologic signs and symptoms? No. Does this rule out brain tumor? Let's evaluate the other criteria. Is brain tumor wide-scoping, simple, and conservative? No. It doesn't account for other signs and symptoms, and it's not very common. With a low pretest probability and negative tests, brain tumor is an unlikely explanation. But it's a don't miss diagnosis, and our threshold for ruling it out is higher, so we'll keep it on the back burner. Our patient volunteers another diagnosis: chronic Lyme disease. In fact, a friend convinced her to get a test from a private lab. The test was positive. Is chronic Lyme the correct diagnosis? Let's evaluate our other criteria. Is chronic Lyme wide-scoping, simple, and conservative? No, she doesn't live in a Lyme endemic area, nor does she recall a rash or joint pain. So chronic Lyme just invokes more questions. How did she get it, and why no classic symptoms? And it's certainly not scientifically well established. Both the CDC and the IDSA have been highly critical of chronic Lyme misdiagnosis. With a very low pretest probability and the poor accuracy of Lyme tests from private labs, her test doesn't carry much weight. Chronic Lyme is a very unlikely explanation for her signs and symptoms. So migraine, so far, is our best explanation. But we shouldn't forget the others. We can start by treating migraines, and with close follow-up, if she doesn't respond or new signs or symptoms arise, we can update our probabilities and reconsider the other diagnoses. And during this process, our patient learned the value of abduction. When forced to compare, she realized there were far better explanations for her symptoms than chronic Lyme. So abduction satisfies all our basic requirements for a description of diagnostic reasoning. Because we're forced to consider alternate diagnosis and compare, we slow down and think, avoiding premature closure and System 1 errors. It makes it okay that our first diagnosis arose from a diagnosis-laden process because there's always another diagnosis to challenge it. Adding the other criteria, scope, simplicity, and conservatism help us evaluate pretest probability and the weight of our tests, all of which help us determine if we ultimately accept or reject the diagnosis. Abduction also fulfills requirements we didn't initially consider, like falsification. Comparison puts us in a falsification mindset instead of a confirmation mindset, avoiding confirmation bias. Abduction turns diagnosis into a process, not an endpoint. With System 2, System 1, and Bayes, diagnosis is all about finding that single diagnosis, which not only leads to premature closure, but is unnecessary to care for a patient. You can address the don't miss diagnosis, start treating the treatable one, and work up the zebras all at the same time. And this teaches us that our best diagnostic tools are actually time and follow-up. Time is a powerful incubator of diagnosis, and follow-up is its guardian. And because the more diagnoses we compare, the more robust our process, a patient's diagnostic suggestions are welcomed. Patients become co-producers of the diagnosis. Instead of shutting them out, we collaborate with them, empower them, teach them, and develop trust. The broad message from abduction is to be comfortable with uncertainty, which really seems to be the key factor in becoming better diagnosticians, and actually a very old sentiment. One of our greatest diagnosticians said it 130 years ago. Medicine is the science of uncertainty and the art of probability. So in summary, the field of medicine has not provided us with an adequate description of diagnostic reasoning. System 2 is only diagnosis testing. System 1 is only the pattern of diagnostic reasoning, and Bayes is only a component of diagnostic reasoning. They all fail to meet, in one way or another, the basic requirements. However, when we search more broadly to describe the reasoning we use in science, we learn that scientific reasoning is an imperfect process called inductive reasoning, not deductive reasoning, and it is best described not by hypothesis testing, but by abduction, or inference to the best explanation. When we apply this back to diagnosis, we derive that diagnostic reasoning is an imperfect process that is more than diagnosis testing. It is abduction. It is finding a disease that is the best explanation for the patient's signs and symptoms. The disease that, when compared with other diseases, is the most testable, fruitful, wide-scoping, simple, and conservative. So if you want to avoid diagnostic errors, you'll need to sharpen your skills of abduction. Remember, all I've done is provide a basic description of diagnostic reasoning. That's it. If you're interested in learning more specific techniques of diagnostic reasoning, there are several courses on YouTube. If you're unfamiliar with the terms cognitive load theory and chunking, illness script, semantic qualifier, key feature, differentiating feature, problem representations, diagnostic framework, diagnostic schema, testing threshold, treatment threshold, you should definitely take one of these courses.